Welcome back to Nephrology Notebook. Today we're reviewing AMPLITUDE-O, a cardiovascular outcomes trial testing Efpeglenatide in high-risk type 2 diabetes. The key question is practical. Can an exendin-based GLP-1 receptor agonist reduce cardiovascular events and kidney outcomes in patients already carrying major cardiometabolic risk? We'll walk through the patient phenotype, trial design, results, safety, and what this adds to our cardiorenal toolkit. The headline finding is that once-weekly Efpeglenatide reduced 3-point MACE and a composite renal outcome in patients with type 2 diabetes at high cardiovascular or kidney risk. Importantly, AMPLITUDE-O enrolled a contemporary population, including patients using or expected to use SGLT2 inhibitors. The benefit appeared consistent across SGLT2 inhibitor strata, but that should be interpreted as supportive subgroup evidence, not definitive proof of additive mechanisms. Let's anchor this trial in a patient like Maria, a 64-year-old woman with long-standing type 2 diabetes, prior myocardial infarction, stage 3 chronic kidney disease, obesity, and blood pressure that is reasonable but not perfect. This is not a low-risk diabetes patient. She sits at the intersection of vascular disease, kidney disease, and persistent metabolic risk. Exactly the phenotype where outcome-driven therapy matters more than glucose lowering alone. Maria is already on a strong foundation: metformin, an SGLT2 inhibitor, maximal ACE inhibitor therapy, and a statin. Yet her HbA1c remains 8.9%, eGFR is 42, and UACR is 350 milligrams per gram. That combination tells us two things. First, she has persistent metabolic risk. Second, she has albuminuric CKD despite modern therapy. The clinical question becomes, what layer of protection comes next? This is the real-world dilemma. One option is to maintain the current regimen and accept residual risk. The other is to consider a GLP-1 receptor agonist. AMPLITUDE-O specifically asked whether an exendin-based GLP-1 receptor agonist could improve outcomes in this kind of high-risk population. The safest interpretation is not proven additivity, but rather, does the benefit persist on top of contemporary therapy, including SGLT2 inhibitors? Type 2 diabetes, cardiovascular disease, and chronic kidney disease amplify one another. Hyperglycemia, hypertension, albuminuria, obesity, inflammation, and endothelial dysfunction all push the same patient toward myocardial infarction, stroke, kidney failure, and death. That is why treating HbA1c alone is insufficient. Modern diabetes care increasingly asks whether a therapy changes clinical outcomes, not just whether it improves a lab value. Before AMPLITUDE-O, much of the cardiovascular outcome evidence for GLP-1 receptor agonists came from agents structurally similar to human GLP-1, such as liraglutide and semaglutide. Efpeglenatide is different. It is based on exendin-4. That made AMPLITUDE-O an important mechanistic and clinical test. Were cardiovascular benefits limited to human GLP-1 analogs? Or could long-acting exendin-based agents also improve outcomes? Efpeglenatide is a modified exendin-4 molecule linked to an IgG4-Fc fragment, which extends its half-life and allows once-weekly subcutaneous dosing. Like other GLP-1 receptor agonists, it lowers glucose in a glucose-dependent manner, so hypoglycemia risk is generally low unless combined with insulin or sulfonylureas. In AMPLITUDE-O, it was tested at 4 mg weekly and 6 mg weekly against placebo. At the receptor level, Efpeglenatide activates the GLP-1 receptor. Downstream, this increases cyclic AMP signaling, enhances glucose-dependent insulin secretion from beta cells, and suppresses inappropriate glucagon secretion from alpha cells. Clinically, that helps lower glucose without acting like a direct insulin secretagogue. But for this trial, the bigger question was whether these metabolic effects translated into fewer cardiovascular and renal events. GLP-1 receptor activation affects several systems relevant to cardiorenal disease. In the brain, it promotes satiety. In the stomach, it slows gastric emptying. In the vasculature, it may modestly improve blood pressure and cardiometabolic risk factors. In the kidney, AMPLITUDE-O showed lower albuminuria and fewer renal composite events. But direct antifibrotic kidney protection was not proven, so we should frame renal mechanisms cautiously. The expected clinical profile is familiar for this class: lower HbA1c, weight loss, modest blood pressure reduction, and gastrointestinal tolerability issues. Nausea, vomiting, diarrhea, constipation, and bloating are predictable because GLP-1 receptor agonists slow gastric emptying and act on satiety pathways. The key practical point is anticipatory counseling. Start low, escalate thoughtfully, and warn patients that GI symptoms are the most common barrier to persistence. The trial rationale was straightforward. Test whether Efpeglenatide improves cardiovascular and renal outcomes in high-risk type 2 diabetes. The investigators also made a crucial design choice by stratifying randomization according to current or potential SGLT2 inhibitor use. That matters because earlier GLP-1 receptor agonist trials included relatively few patients on SGLT2 inhibitors, leaving uncertainty about whether benefits persist in combination-era diabetes care. AMPLITUDE-O was an international, randomized, placebo-controlled trial conducted at 344 sites across 28 countries. A total of 4,076 participants were randomized in a 1:1 ratio to efpeglenatide 4 mg weekly, efpeglenatide 6 mg weekly, or placebo. The two efpeglenatide arms were combined for the primary analysis. Median follow-up was 1.81 years, which is clinically meaningful but still relatively short for kidney outcomes. The cohort was intentionally high risk. Patients needed type 2 diabetes with HbA1c above 7%. They qualified either through established cardiovascular disease, such as coronary disease, stroke, or peripheral arterial disease, or through kidney disease with additional cardiovascular risk. Key exclusions included recent GLP-1 receptor agonist or DPP-4 inhibitor use, severe gastroparesis, and prolonged nausea or vomiting. This selected for patients likely to tolerate and reveal outcome effects. The baseline population was exactly the kind of group where event rates are high enough to test outcomes. Mean age was 64.5 years. Diabetes duration was about 15 years. Nearly 90% had established cardiovascular disease, and about 1/3 had eGFR below 60. More than 15% had SGLT2 inhibitor use at baseline or during the trial. This was not early, uncomplicated diabetes. This was advanced cardiometabolic disease. The primary endpoint was 3-point MACE: non-fatal myocardial infarction, non-fatal stroke, or cardiovascular or undetermined death. The key renal composite included incident macroalbuminuria, sustained 40% or greater eGFR decline, renal replacement therapy, or sustained eGFR below 15. For nephrology teaching, the endpoint composition matters. A renal composite can be statistically positive, but still be driven mainly by albuminuria rather than hard kidney failure events. The primary outcome favored efpeglenatide. MACE occurred in 7.0% of participants assigned to efpeglenatide versus 9.2% assigned to placebo. The hazard ratio was 0.73, with a 95% confidence interval from 0.58 to 0.92. That corresponds to a 27% relative risk reduction and an approximate number needed to treat of 46 over 1.8 years. The trial met non-inferiority and showed superiority for MACE. The cardiovascular signal extended beyond the primary endpoint. Expanded MACE, including revascularization or hospitalization for unstable angina, was lower with efpeglenatide, with a hazard ratio of 0.79. The composite of MACE, or non-cardiovascular death, was also lower, with a hazard ratio of 0.73. Individual components were directionally favorable, but the strongest interpretation is that the overall composite cardiovascular benefit was consistent. The renal composite was reduced from 18.4% with placebo to 13.0% with efpeglenatide, with a hazard ratio of 0.68. That is a 32% relative risk reduction. However, nephrology viewers should notice the composition. Incident macroalbuminuria was a major driver of the renal endpoint, so the careful wording is that efpeglenatide reduced a renal composite outcome with a strong albuminuria signal, rather than definitively proving prevention of kidney failure. Subgroup analyses supported consistency across clinically important strata. The hazard ratio for MACE was similar whether patients were using an SGLT2 inhibitor at baseline or not, and results were broadly consistent across baseline eGFR and metformin use. But subgroup analyses should not be overread. They support the idea that benefit was not obviously restricted to one subgroup. They do not prove biological additivity between GLP-1 and SGLT2 pathways. Efpeglenatide improved several intermediate risk markers. HbA1c was lower by 1.24 percentage points, body weight by 2.6 kilograms, systolic blood pressure by 1.5 millimeters of mercury, and UACR by 21%. These changes may help explain part of the outcome benefit, but they probably do not tell the entire story. The key teaching point is that small shifts across multiple risk pathways can translate into meaningful event reduction. Safety was largely consistent with GLP-1 receptor agonist class effects. Discontinuation due to adverse events was higher with efpeglenatide, 5.4% versus 3.6%. Severe gastrointestinal events were also more common, 3.3% versus 1.8%. Reassuringly, confirmed pancreatic events and severe hypoglycemia were not significantly different. In practice, tolerability counseling is not optional. It is central to whether patients can stay on therapy long enough to benefit. AMPLITUDE-O had several strengths. It was large, international, randomized, double-blind, and placebo-controlled. Outcomes were clinically meaningful and adjudicated, and the trial deliberately addressed SGLT2 inhibitor use through stratification. The enrolled population also had substantial cardiovascular and kidney risk, making event detection more feasible. The main strength is not that follow-up was long, it is that the trial was rigorous and targeted the right high-risk phenotype. The limitations matter. Median follow-up was only 1.81 years, which is short for definitive kidney disease progression outcomes. The trial also ended before the pre-specified target of 330 primary events because of a sponsor funding decision, unrelated to trial data. Finally, the population was highly selected and high risk, so results should not be automatically extrapolated to younger, lower-risk, early-stage type 2 diabetes patients. The synthesis is best framed as a hypothesis of layered protection. SGLT2 inhibitors and GLP-1 receptor agonists act through different dominant pathways: hemodynamic, natriuretic, metabolic, weight-related, and possibly vascular effects. AMPLITUDE-O supports the idea that GLP-1 receptor agonist benefit can persist in a population where SGLT2 inhibitor therapy is present or anticipated. But it does not prove that the two mechanisms are strictly additive in a mechanistic sense. Returning to Maria, AMPLITUDE-O helps us explain why adding a GLP-1 receptor agonist is conceptually attractive in a patient with established cardiovascular disease, stage 3 CKD, albuminuria, and persistent hyperglycemia despite foundational therapy. In a similar high-risk population, Efpeglenatide reduced MACE and the renal composite. The clinical conversation would include expected HbA1c and weight reductions, GI counseling, cost and access, and individualized risk-benefit discussion. 3 practice implications stand out. First, cardiovascular and renal outcome benefits are not limited to human GLP-1 analogs. AMPLITUDE-O broadened the evidence base for long-acting exendin-based agents. Second, do not dismiss GLP-1 receptor agonist therapy just because a patient is already on an SGLT2 inhibitor. Third, in patients with eGFR below 60 or albuminuria, kidney risk should actively shape diabetes therapy, not sit in the background. The final takeaway: AMPLITUDE-O showed that Efpeglenatide reduced 3-point MACE and a renal composite outcome in high-risk type 2 diabetes, supporting layered cardiometabolic and kidney risk reduction in selected patients. For Nephrology Notebook, the nuance is the message: real benefit, cautious mechanism, and renal outcomes that require endpoint literacy. If this was helpful, subscribe for more landmark nephrology trial breakdowns and share it with your team.